Good morning. I'm Guy Odishaw with Bhakti Brain Health Clinic. My background, I've been in practice for about 35 years. I started off in integrative manual therapies, into bioelectric medicine, and then into neurotherapy, so doing neuroimaging, neurofeedback, neurostimulation. Co-founder with Fran of the Bhakti Brain Health Clinic for about the last 8 years. And then here we are today. Fran?
I'm Fran Bieganek. I'm a licensed psychologist, been in practice 30 plus years, specializing primarily in working with trauma and first responders. I've also taught at the state college system and, as Guy said, have been a part of the Bhakti Brain Health Clinic for about 8 years, and we're looking forward to talking with you this morning.
So I get to start us off today with just a little bit of an overview. So we always include this slide because there's many forms of neurofeedback. And so you say neurofeedback and people might nod and say, oh, I'm familiar with that. But what they may not know is there's 100 different kinds of neurofeedback, and even more than that, it's worse. So to try and understand when we say we do neuroimaging and neurofeedback, certainly people familiar with the industry will know that it depends on the equipment you have. So what type of hardware do you have? What type of software do you have? Who did you mentor under? All of those things kind of tell a clinician, like if we're going to make a referral, those are the things we want to know of the clinic we're going to refer to, because that tells us what kind of neuroimaging and what kind of neurofeedback they're capable of, and therefore we know if it's a good fit. So it's a little bit like saying you're going to refer somebody to pharmacy, right? They have a lot of pills. You might want to know what pill your person needs, and does that pharmacy have it? Same thing for us. So one of the big questions that we always get, so we like to answer this right off the top, is there research? We were asked that. Most everybody who stopped by the booth asked that question. The answer is yes. Here, give you a little bit of a breakdown of the number of studies kind of in these areas related to neurotherapy for the brain across different forms of neurotherapy. And then took out missing the big slide. So for neurostimulation, so a large category, there's about 3 million studies. So this has been studied for about 60 years. There's a lot of quality research. Everything we're going to talk about today is evidence-based. Everything we do in our clinic is evidence-based. And that kind of, as a clinic, that's the decision that we've made, is to stay with what does the research show in terms of efficacy and positive clinical outcomes. So one of our things that we're very much focused on is this idea of precision assessment. So often people will go, if we talk about, say, an ADHD or an ASD assessment, they'll have a behavioral assessment and maybe a neurocognitive assessment. And that's great. That's kind of standard of care. We do a behavioral assessment and a neurocognitive, but we add to that the neuroimaging so that we can see what is that individual brain actually up to. What areas of communication, what parts of the brain are talking to other parts the way they should, and what parts aren't, and how aren't they, so that we know what kind of intervention to do. In our clinic, we see about 50% of the properly performed diagnoses that come to us are wrong. When we look at the EEG, they don't fit the phenotypes for the diagnosed condition. So an ADHD probably being the biggest one. About 50% of those are incorrect when we do neuroimaging. And what that means is the care plan that person would be given, and maybe it's medications, maybe it's just behavioral, are not necessarily fitted for the dysregulation they have. And it's one of the reasons we don't see great outcomes when we look at behavioral interventions into these conditions. If we can understand what's happening in the brain, we can craft that intervention specifically for what that brain needs. So one of the examples we like to use is if you went to see your cardiologist, you would not want your cardiologist to watch you walk around the room, ask you a couple of questions, do you love your mother, and then diagnose your level of heart disease. You wouldn't want them also, it used to be, standard of care, it's still a fine thing to do a stress test, but it doesn't tell you about the health of that organ. What do you want your cardiologist to do? You want them to do a calcium scan. So you can just see how much blockage is in the arteries. And if you've got arteries that are at 90% blocked, you want an intervention. So you might do fine riding the bike, but you might also have a 90% blockage. You want imaging. So we often say that mental health is the only profession that doesn't image the organ they work with. So we're changing that by doing imaging as part of an overall intake and assessment and addressing and creating treatment plans. So what about neuroimaging? So QEEG So you see here some of the components of it. What do we look at? We look at overall kind of amperage. We're going to get to see that in an example here. We're going to show you some EEG, and we're going to do a little breakdown on what you're seeing and how we can change it. So we just look at the raw EEG itself. Does it look neurotypical? Does it have as much amperage as it should? We look at communication patterns. Is one part of the brain communicating with another part of the brain the way it should? An example of this might be, let's say you sit down with somebody at lunch and they're talking French and you don't understand French, and you're talking English and they don't understand English. You can have a conversation, but nobody walks away from the table understanding what was said. So if in the brain, that would be if two areas are supposed to be talking at 7 hertz and they're talking at 6 hertz, wrong language. One part doesn't understand what the other part is saying. So that's what we look for, is the nature of the communication pattern. We look at how is information moving around networks. The game of telephone, right? You say something and it goes around the room, and by the time the message gets back to you, how much has it changed? That's network function. So we want to know the fidelity of information within a network, so that when one region starts some computation and it passes that on to 40 other regions, that the fidelity of that message is staying. So an example of this might be dyslexia. So dyslexia is a breakdown in the network that is involved in understanding how to put letters together to make words and put it in a sentence and give it meaning. If you lose fidelity, one of the things you can get is dyslexia. So from us, it's a network dynamic. We would try and improve network dynamics so that symptom called dyslexia didn't show up. So here's a great example. So there's a lot of things that people will say, particularly neurologists will say this, people who are in the EEG world, that EEG is just an epiphenomena of neural activity. There's no information in it. It's of no value. Some people will say, well, it's too noisy. Right? Our method of imaging the brain with electricity isn't good enough. So it's a chart like this that says that is just wholly not true. What you're seeing here is a small study where they had a person looking at the letter on the top chart, doing EEG, so reading the neural firing patterns, and then extracting out of that the image in the visual cortex. So you can see examples of 3 people in the study. And you can see that like the A looks a lot like an A. And that A is reconstructed out of the neural firing patterns. What I'm trying to say here is this is incredibly precise. That we are at a point in neuroimaging where we can start to read people's thoughts. I mean, it sounds a little spooky, sounds a little science fiction, but it's actually happening. You can be listening to music and the EEG can tell what song you're listening to. So there's highly accurate, and that's what helps us do that precision assessment, because we can see how information is moving around in the brain or where it's not moving around. So here's an example. So some of the things that we look at, again, is how is information moving? What is the timing of information moving around? Think Grand Central Station. When Grand Central Station, all the trains are timed, people come in, you get off, you walk to your next train, you get on, you get to where you're supposed to be on time. If the trains are off time, you show up late, your train has already left. You show up, but the train that you're supposed to get on has the wrong name on it. You get on the wrong train, you end up where you're not supposed to be. That's what's happening in the brain. That's what this is a measure of. So what should happen here, see if I can get my pointer to work, is these numbers down this column should ideally be 10. So 10 hertz, alpha, 10 hertz is what the typical brain's internal timing mechanism should be. It should be running at 10 hertz. That's neurotypical. It could be at 9, it could be at 11, that's fine, but they should all be the same. What do we see here? These are not all the same. We go as low as 7 and as high up here around 12. So this brain is not in sync with itself. Some parts are running fast, some parts are running incredibly slow. Information processing, Grand Central Station, a lot of people are missing their trains. These are the kinds of things that we look for to help us understand where things are going wrong. And then we go into the treatment side of how do we correct that? How do we reset the timing mechanism in this brain so information gets to where it's supposed to get to so it can be in the next round of computation. So here's some of the things that we do. So neuroimaging often leads to neurofeedback. So neurofeedback is we think of it as a learning paradigm. The brain is being given kind of a problem, a challenge. So maybe that's flying an airplane, driving a car, making a light bulb light. There's some challenge to the brain, and the brain has to figure out how to do it. The person doesn't get any tips or cues or anything. The brain is just giving feedback of either being successful or not being successful at let's say, flying the plane, which we'll see an example of. And what they're getting is that their EEG is being compared to a normative database, and they're either moving towards that normative database, so a neurotypical way of moving information through the brain, or they're not. When they are, they get rewarded by positive, the plane flies straight, the light bulb lights, the music gets louder. If they're not moving information the way they're supposed to, they get some kind of negative feedback. The plane wobbles, the music gets quieter, the light bulb gets dim. With just that little bit of feedback, the brain will figure this out in seconds, in minutes. Our mind could be completely paralyzed by that. Like, oh, like, what, you want me to do what? Make information move in my salience network in a neurotypical way? I have no idea what that means. But for the brain, no problem. So that's what we do. We watch brains rewire themselves live in front of us. It's amazing. So that's neurofeedback. We use neurostimulation. Neurostimulation is a little bit more of a therapy paradigm. We're actually kind of nudging the brain. We're kind of telling it what to do versus kind of offering it an opportunity to figure out for itself, learning paradigm. Neurostimulation, therapy paradigm, we're kind of nudging it, giving it hints at what we want it to do. And then we have at-home neuromodulation. So we have devices that are kind of the same way, kind of helping the brain self-regulate in a very generalized way. So these are some of the tools that we use in neurotherapy. We're going to go into it in a little more detail here, maybe. There we go. So you can see the person in the chair, they've got a cap on their head. That's collecting the electrical activity at the scalp, so the near electrical field. Taking that into the computer, comparing it to an age and gender matched database of neurooptimal brains, so peak performance brains. And then again, he's flying a plane. When the plane wobbles, that's feedback to the brain of like, you just kind of went off what you're supposed to be doing. The brain had a little moment there, it wobbled. When the plane's flying straight, he's getting feedback that the brain is moving information equal to the normative database. So we'll see here in a moment, we'll get let's see. So there you can kind of see the screen, what we're looking at. So we're seeing the EEG. These are all of the metrics that this brain we found through doing the neuroimaging, where the brain is not moving information, not doing what it's supposed to, what we would call dysregulation. So in this case, we might be training 500 different brain metrics at one time and moving those towards a more neurotypical pattern of firing. So here this is HRV or biofeedback. So we also track the body and the biometrics. So what is your skin temperature? What is the conductivity in your skin? So kind of a sympathetic, parasympathetic measure. Heart rate variability, how well is your autonomic nervous system regulating your body? So we track that at the same time we're tracking the brain. So we like to say brain, central nervous system, top down, body, autonomic nervous system, bottom up. We look at both and we help people regulate both ends of the nervous system. Okay, so here we're going to see some EEG, and actually you are looking at Fran's brain. So she was kind enough to donate her brain to science. So what you're seeing here for probably the first 30 seconds, first 30 seconds is just kind of kind of normal EEG. So she's got an audiovisual entrainment device on. So this is the flashy glasses, the binaural beats in the ears, and it's on an alpha protocol. So she's getting a 10 hertz alpha pulse in the eyes. And you're going to see right there, so these are alpha bursts. So already we're seeing that her brain is moving into entrainment. Her brain is taking on the pulse rate that we're giving it. And as we go on, you'll see another burst here. And then towards the end, you'll see much more sustained alpha activity. So within minutes of putting on the stimulation, the brain is changing its pattern of neural firing. So there we see more alpha, and there you see the beginning. And now you can see these large. So now her brain has really moved into an alpha state. And this happens within minutes. People will often ask us, how many treatments do I need for this to work? And we say 3 minutes. Now, 3 minutes to change how your behavior is? No. 3 minutes to change what your brain is doing? Yes. How does changing your brain translate to behavior? That's a bigger question, right? There's all kinds of things. The distance between brain activity and behavior is a huge gap. When we're working in the neurotherapy clinic, we're focused on brain activity. When we're in the mental health clinic, we're talking more about on the behavioral side. course, in our clinic, we bring the two together and look at how do we change the brain, how do we change behavior, and how do we optimize that. Okay, so here you're seeing an example of a client doing neurostimulation. So they're just laid back in a chair, got a little teddy bear there, taking a nap, getting transcranial electric stimulation and transcranial magnetic stimulation. So we often will combine a TACS, so a transcranial alternating current stimulation, with a transcranial magnetic stimulation, and also a transcranial photobiomodulation or light. So usually a red and near infrared light. And we'll combine all three of those together into one treatment. And then we can change the frequencies, again, to encourage the brain, like you saw in Fran's case, we wanted to show more alpha, produce more alpha. We might, in some case, want to get somebody who's maybe running a little bit slow to speed up the brain, so we put in more of a beta. If we want to improve focus and concentration, we put in a specific type of a beta, a spindling beta into the frontal lobes, and that will tend to get the frontal lobes kind of sparked up and running, and particularly perform well in academic measures. On the other hand, if you have somebody who's anxious, we might want to slow the brain down, so we put in more of a theta, and we kind of help settle the brain. So we can change what we want the brain to do by changing the nature of the stimulation. So next we're going to see a series of videos from a fMRI pilot study that a colleague of mine did doing neurostimulation with the person in an fMRI. So we're going to see 3 videos, and then I'm going to show you the net out of that, because it goes by pretty quick and it's a little hard to track. So we'll do a still image comparison. So what you're looking for here is, you see the fMRI is how much green. So green to red is kind of blood use oxygenation level. So in our first one, this is the normative one. This is 5 minutes before the stim happens. And you can see there's a little bit of green, but mostly kind of the dark colors. So this is kind of what you would expect from a brain at rest, laying there doing nothing. So this one is our during. So their brain is being stimulated. So again, it's a little hard to track when you see one after the other, but we have more green in more places in this one. More brain activity, more oxygen, more blood flow. And then, I don't know that advanced. That was the same. That was the during again. So let's try this one. This will be this is our post. So this is 5 minutes post. And again, we'll see in a moment in the comparison that the 5 minutes post stimulation, we still have an increase over baseline of cerebral oxygenation and blood flow. So we've, only 5 minutes out, but we show that it's sustained after the intervention. Okay, there we go. So there is our pre, during, and post. And so you can see here in the still that roughly try to get the variables set so that we're looking at similar slices of the brain, the best you can do in a moving MRI. But you can see that we get more activity during stimulation. So this is a great pilot study, and what we're hoping is that she will continue on and be able to do a fuller study and be able to see what happens when we change the nature of the stimulation. So this one was just a basic, like a vagal nerve stimulation. So we just kind of picked something that was somewhat generic, and we had an anticipation of how it would change the brain, and we saw what we thought we would see in terms of what parts of the brain increased in blood flow. So it mapped onto the hypothesis well. So the hope is we can continue the study and do more forms of neuroimaging and show that they do change the brain in predictable ways, leading to a better understanding that it does matter what protocol we do. It brings back that piece that precision matters. Just kind of generically throwing something at the brain that we think is good doesn't necessarily get you the change that you want. Precision matters. Okay, speaking of precision, Fran is going to come entertain you now, and she's going to take you through some...
Guy, will you keep an eye on time and just let me know when it's about noon?
About 2?
Noon. Yeah, 2. You guys want to hang out until 2. Happy to do that.
All kinds of time.
Guy has done a fantastic job of introducing you to this idea of why it's so critically important to think about the brain when we're considering students and how they perform and the struggles that they have and that you bump into with them. And so what we want to do for the rest of the time is use I'm going to introduce you to 4 students. Tinker, Taylor, Soldier, and Sailor are all just student profiles, kind of the typical sorts of things that you might see a student struggling with. We want to kind of shift the perspective to move away from just kind of looking at the behavioral and emotional pieces of things to really kind of taking in that idea of what's happening in the brains of these students that may be contributing to what you are seeing them struggle with. Our whole reason for doing this is to really kind of bring home the idea that without looking at the brain, every single thing that you do with them is potentially compromised, because if the brain isn't working well, then it doesn't matter how many skills you have, how many things you throw at them, how motivated they are to change. It's kind of like if you wanted to train me to run a marathon and I'm, trying my best, you're teaching me skills, but something's looking a little funky in my run. And we finally decide to look at the foot that's not doing the thing it's supposed to do, and we image it and say, oh my gosh, you have broken bones in there. Let's take care of that. And then I bet you're going to be able to do these skills better and run the race, right? That's what we want to encourage you to think about as we talk about these student profiles. So student number 1 is Tinker. Tinker is somebody who maybe presents with some generalized anxiety, maybe has test anxiety, perfectionism, really struggles with kind of getting tasks done, right? Because of that tendency to overthink, which is a perfectionistic quality. Tinker is a worrier. And so if you look over on the right, what you see is that Tinker's brain has likely been struggling with some excess fast waves, so beta wave, high beta wave, particularly in the frontal lobes. So you would not know that sitting there with Tinker, because Tinker's not going to have a little thing going across saying, ooh, beta wave, too much beta wave, right? The only way you know that is if you've been able to look at Tinker's brain. However, if you're armed with some knowledge about this, you have potential to appreciate that that might be happening. And then there are some ways that you can intervene that can be helpful, and we'll talk about those in a minute. Then we have Taylor. Taylor is our drifter. So Taylor is the one who they kind of are, you catch them looking off into space oftentimes, and you wonder, where are they, right? That tendency to kind of be distracted, a difficulty with finishing tasks, becoming what appears to be pretty easily bored. So this is the drifter, right? Tinker's brain is kind of stuck in like a low gear. And so a maybe typical profile, EEG profile, and keep in mind, this is not like, there are nuances to what we see in EEG. So we're just kind of generalizing some of this. But typically with your drifters, so oftentimes this is somebody who will come in and everybody thinks this kid's got ADHD, right? Maybe they do, maybe they don't, but they certainly have symptoms that are indicative of that. So oftentimes these are kids who, like, it wouldn't be unusual if we did a QEEG with Taylor to see that Taylor has a lot of excess slow wave activity, theta wave, particularly in the frontal lobe. So Taylor's going to be like struggling with a brain that is almost like in a state of hypoarousal, right? Not enough arousal, particularly when attention is required. And so if the brain is not stimulated enough during that time, what you're going to see perhaps as kind of the output of that is all of what we see with Taylor here, right? That distractibility, the inability to pay attention for very long, getting bored, those sorts of things. And then we have student number 3, Soldier. Soldier is a survivor, oftentimes a survivor of developmental trauma. Soldier is kind of in a state of a lot of chronic stress. So oftentimes what we see with Soldier is hypervigilance. We see somebody who maybe has emotional outbursts, somebody who is constantly kind of thinking, right? This is a safety mechanism, right? And so if the brain is sort of always looking out here and thinking and watching out, it's not going to likely do a good job of attending to the stimuli that it needs to attend to, especially like we're talking about in a school setting here. Soldier's brain is kind of locked in survival mode. And so a brain that's locked in survival mode is not going to function optimally at the tasks that will be required of Soldier in her classrooms. So oftentimes what we see with trauma survival, it's any kind of developmental trauma, dysregulation in the limbic system. We can also see poor integration between the hemispheres, but also kind of the cingulate, which plays a significant role in both emotion awareness, processing of emotion, and then also kind of what the brain decides to do with emotion. And you and I would call that how the brain reacts to emotion, right? So oftentimes we can see somebody who is emotionally dysregulated because of that struggle with the cingulate connectivity, or it could be one like the anterior or posterior part of the cingulate that might be struggling specifically. And so lots of poor emotion regulation. This is a brain that just kind of can't get out of that fight-flight mode, right? And then our fourth student, this is Sailor. Sailor is low energy, apathy, oftentimes looks depressed. Sailor's brain is likely stuck, lacking some like internal drive, internal energy. And so what we oftentimes see in EEG with this type of a brain is that it's oftentimes just kind of across the board, low amplitude, it's a low voltage brain. We oftentimes see, like in the reward, there's literally a network in the brain that is responsible for the brain being able to recognize what's pleasurable and move toward it, and recognize what's displeasurable and move away from it. That's the reward network. Oftentimes that can be extremely dysregulated in somebody who has the profile that we see in Sailor here. And so they just have difficulty generating enough energy to engage in tasks. So that's our students. So this is the thing. If you are armed with even this little bit of knowledge and understanding of how the brain works and the importance of considering what's happening in the brain, this is your power move then, right? Because you can take all of those fabulous skills that you have in your toolbox that you use on a daily basis to work with your students, and you can add in this understanding that maybe before I have one of my students try to engage in an emotion regulation skill, maybe what we're going to do is make sure the brain is in a spot where it has capacity to do that, right? So we'll talk about the how of that in a minute. The kind of moves you into this place of, rather than just managing symptoms, you're building kind of true neurological and physiological resilience in the child, right? So the idea being, in the long run, it won't just be that like Sailor's going to be managing these symptoms, you know, in 3rd grade, 4th grade, 8th grade, you know, as a senior, but rather that perhaps you can help them to build some resilience around that. Ultimate goal being some self-regulation, cognitive flexibility, all of those things that are crucial in order for them to be successful in school, certainly, but not only in school, at home, in social relationships as well. So this is an example of a classic kind of treatment-resistant anxiety biomarker. So this is kind of a collage of some information that we might get from different analyses we do with the QEEGs. This is an independent component that's pulled out, and what you see here is you can see that there is, let's see if I can get the pointer to work here. Right here we see, this is, remember when Guy was talking about the peak alpha? This is a little bit low here, so this is hertz across the board here. So this is 10 hertz. So this peak should be happening right at 10 hertz. So it's a little bit of slow alpha going on there. But we also see one of the lovely things that we can do with QEEG is we can get as specific as being able to know what Brodmann area might have a particular type of dysregulation. And so this tells us, this image actually tells us, you can see over here, it says Brodmann area 31. That's in the posterior cingulate. Remember I was talking about the cingulate in regards to motion, emotion processing? and regulation, that's Brodmann area 31. That's one of its critical markers here. And this one is, you can see it's pretty dysregulated. You can see that the dysregulation, so if you were looking at it, Brodmann area 31 is about right there, but that dysregulation is kind of propagating out into different areas of the brain as well. So this is possible that if we were to do a QEEG on Tinker, that's what we would see, is one of the findings we might find, is that kind of classic biomarker here. And so despite the fact that Tinker might have good intentions to try and manage anxiety and some of that hyperarousal, he might struggle with it because of that dysregulation. So oftentimes we talked about this when we were introducing the student profiles, so that frontal high beta oftentimes is kind of the bugger here, right? It's the thing that's getting in the way. So the goal would be to turn down the volume of that fast beta wave, right? To kind of balance it out more. So what that will tend to do is then reduce there can be a kind of a racing thought loop that happens when you have excess high beta in the frontal lobe. And as you tamp that down, right, turn it down some, it's going to allow the brain to engage some of its more calming processes. So I'm going to talk about the how we could do it, but then we also want to talk with you about, as a counselor in the schools, because you don't have access to our 19-channel neurofeedback equipment, what you might do in regards to helping Tinker to be able to kind of calm down their frontal beta and regulate their emotion better. So in clinic, we would likely look at doing some 19-channel neurofeedback. We'd identify what networks are really dysregulated for Tinker, and we'd be working on that. We might do some neurostimulation, as Guy had mentioned earlier, to help kind of get the brain to start producing. We might give it like a parasympathetic protocol to have it start kind of just getting into sympathetic mode, right? So those are things that we would do on our end as a way of kind of long-term helping this brain to regulate and then stay well regulated. In your realm, you could add in audiovisual entrainment. So many of you probably have stopped by our booth and seen the goggles and headset, right? That's what audiovisual entrainment is. Built-in protocols that are really good for regulating emotion. And so we have tons of people, you guys talk to a lot of you. I see some familiar faces in here, but like we can take somebody who's in a full-blown kind of fetal position panic attack, and within 5 to 7 minutes have them kind of settled enough that they're able to kind of relax into their body a bit more, begin to have a little bit of conversation, and then over the time of the treatment, they are able to get that brain into more of a calm state, right? And then that will last for some time throughout the day. So that's something you could do. We have schools that have AVEs sometimes in their resource rooms, some people call them comfort rooms, that will use this for this particular reason, right? So that they can take a kid who's gotten really dysregulated, give them a protocol, and then they can go back into the learning environment and actually learn. And so that can be helpful for the student as well as the staff that are working with the student. And then likely for Tinker, we would want to do heart rate variability. So we do that formally in the clinic, but it's also something that can be done like on a more informal basis, something that like as a counselor, you would be able to kind of help a student engage in like paced breathing. Okay, all right, thank you. To engage in paced breathing and that sort of thing. So that combination, the idea again, hit the top down and the bottom up to regulate that student. And then from a counseling, like from your counseling skills strategy, the idea is cognitive reframing is always good with people with anxiety, right? Because they always get into catastrophic thinking, right? But if the foot bone is broken, I can't run the race, right? So if the brain is dysregulated, it's got all that fast beta wave going on, there's no way the reframe can happen, right? They just can't access their logical processes to be able to think about that. So cognitive reframing, good, but first, calm the brain down. And so that's kind of the key here, right? Take the brain, deal with it there, then engage in your strategy. I guarantee you they will go much better at that point. Breathing exercises can be really good to do. Again, the heart rate variability would be great for that. I'm going to talk quickly because time. So this is an example of what is called a high theta beta ratio. So you can see over here, this is showing anything that's kind of in the warmer colors here is standard deviations above the norm. Something gray would be neurotypical. So when a theta beta ratio is high, what that means is there's too much theta. Theta is a slow wave compared to beta, which is a fast wave. And when that happens, we can see drifters, right? And so theta beta ratio, high theta beta ratio, is a classic biomarker in EEG for somebody with ADHD. It's not the only one. There are actually 8 different EEG profiles for ADHD. This one is classic. And so the goal here would be to get less of that slow wave going so that the brain can actually engage in cognitive activities better, right? And so again, we might do it with neurofeedback, we might do some stimulation. Audiovisual entrainment, again, has wonderful protocols for that. Give us low beta protocol, an SMR protocol, something like that, or even maybe in the beta range, to really kind of get that brain to be able to get into a state where there's enough fast wave that it can engage in the cognitive processes that it needs to in order to be successful. So from the counselor end of things, important, first of all, that this student gets movement breaks, all right? They need those movement breaks, especially while that brain is dysregulated. It's just going to keep kind of doing some of that. Structured attention tasks that align with the brain's need for that novelty and arousal. Keep in mind, the brain is kind of slowed down, right, with all that theta wave in it. And so to get it going, it needs maybe novelty. And so it's not that they're bored, it's that the brain needs some more energy put into it. And so novelty of task, when you're wanting them to attend to things, can be really, really helpful. This is one example of frontal lobe disengagement. So this is an example of a mu rhythm. So you see this here. This is a mu rhythm that is kind of across it shows up across the motor cortex. When this pattern shows up in EEG, what it does as it presents is there's a disengagement of the frontal lobe. And so we see this pattern happen oftentimes with people with developmental trauma. There's some strong correlations there. The belief is that it's a compensatory mechanism that the brain has engaged in. Can't deal with the traumatic, all of the chaos in the environment. It has to just kind of back off for a minute, and so it disengages the frontal lobe. Right? And so there can be this pattern of a mu rhythm going, kind of happening repeatedly. And so as you can imagine, if somebody's going through their day with frontal lobe disengagement happening on a regular basis, it's going to make it difficult for cognitive tasks. It's quite possible, soldier, your survivor, could have this, right? That she has some of this mu rhythm showing up in her brain. It's also possible she could have some inconsistent power and coherence in the brain, oftentimes some delta and theta spikes. So again, slow waves that are kind of pulling away from the cognitive processing. And so the goal would be to restore that, improve limbic system regulation, that sort of thing. Again, on our end, we're going to do the same things that we would do. We're just going to be specific about it based on what we see in the QEEG. The AVE, again, can be extremely good for this. For soldier, oftentimes soldier might just need some emotion regulation, right? Some alpha wave might be really nice to just go into a state of calm, right? And presence in that way. And so again, this could be really helpful to utilize the audiovisual entrainment with her. Soldier could also benefit extremely well from doing some kind of HRV paced breathing as well. If you have any interest in that and questions about that, contact us, to stop and talk to us after the session, and we can talk with you about resources around that. For you as counselors, one of the primary things for this brain is some predictable routine, right? Because the only thing predictable in soldiers' experience is unpredictability, right? I never know what's going to happen, and so I have to be vigilant, right? That's not soldier thinking that. That's what the brain is doing. It's just staying on alert. So that predictable routines, safety anchors, right? A place for soldier to go, a person that soldier has. Maybe soldier has a particular something that is an object of safety for them or for her, right? And so those kinds of things can really help. And they not only help soldier, but there's a dynamic process going on between environment and brain function, right? And so it can aid in that as well. And then obviously the things that you all do super well, I would imagine, are, things like grounding techniques, helping kids learn how to label emotions, that kind of thing, to take them, because part of the reason that can be difficult is, again, if there's like the frontal lobe is disengaged, if there's too much slow wave going on, they just don't have the cognition processes to do that. All right, I'm going to talk very quickly about this, and then I promise I'm done. So this is an example of a low energy brain. You'll notice the excess over here. Again, there's not a bit of gray in the delta or theta. There's way, way too much fast wave here. That is likely what we'd see with Sailor's brain, right? This is the kid that looks depressed, the kid that behaves in an unmotivated way, the kid that seems kind of checked out. Oftentimes, this is what's going on from a brain function standpoint. Again, we would do the same things that we might do with our in-clinic options. Audiovisual entrainment, this brain needs beta wave badly. Right? And so if Sailor was my student, one of the first things Sailor would do every time he came into school every morning is he would put on an audiovisual entrainment device for 15 to 20, maybe 30, if we can spare it, minutes of beta, right? Get his cognitive processes functioning, right? That's what that would do. And if you do that on a daily basis, that brain has opportunity to stay in that state more frequently. And while this is just a treatment, so it's not the learning paradigm that neurofeedback is, if it's a daily thing, the brain just gets accustomed to it, right? And so it's going to move there more quickly. That's a sure way to get Sailor to be more successful and engaged in his life. And then physical activity, you guys should be prescribing physical activity. If that means walking with them because you need to motivate them that way, that's great. And then also kind of those tiny achievable goals. Remember all of the slow wave. Until that slow wave changes, they don't have capacity to do it in bigger chunks, right? Maybe if you throw on the beta protocol, you can start to make those tiny achievable goals a little bit bigger and a little bit bigger over time. So questions at this point in time from any of you? Yeah, go ahead.
Yep. Yes, absolutely. TBI is a common referral for our clinic. A couple of things. So Fran had just finished talking about the effect of slow wave. That's one of the main things we see in concussion. The brain kind of goes into a little bit of a survival mode. So it will slow down, but it'll also lower the overall amperage. So we call it a low voltage EEG. So it goes into a power saving mode. And so we can see changes in amplitude, changes in slow wave activity. And then the other thing that you can pretty much count on in concussion is impact on the autonomic nervous system. So then the body isn't being regulated properly. And one of the effects of that is then the brain isn't getting the blood flow, the nutrients, the other, oxygenation, all the things that it needs because the body isn't being well regulated. So it's kind of creates a bit of a negative feedback loop. So for concussion, I think audiovisual entrainment is a great option. Again, just generally regulate the brain. Transcranial photobiomodulation, so red near-infrared light. Particular near-infrared light, one of its main things is it's anti-inflammatory. Chances are in a concussed brain, we're going to have inflammation. So being able to bring down that inflammation as fast as we can. It also does 35 other positive things. So there's a lot of positive that comes. We have some great case studies that show before and after from somebody with a TBI, the negative sequelae of that, the symptoms, a single treatment of photobiomodulation and how much improvement there is. It's just night and day difference. So yes, there's a lot that we can do for TBI, and we great outcomes from that. And it doesn't have to be fresh. I mean, one of my clients that I treated that had quite significant autonomic dysregulation, he could fall asleep in the lull in a conversation. He could fall asleep. And that was from a concussion. He was, probably 25 years earlier. But we were able to treat the spot of the concussion, treat the dysregulation in the autonomic nervous system, and he went from somebody who couldn't stay awake for a minute while training to being able to stay awake for 45 minutes. So, yeah.
Start here and then there. Sure. So I think our youngest has been 4 and our oldest 80 plus maybe. And so maybe typical is somewhere in the early elementary through, I don't know, adulthood kind of.
We really do work the full range.
We do have a lot of kids that fall in the school range. Yep. Yeah.
So a couple things in response to that. So like number of visits needed. So we can think of something like what we're talking about here, potentially a audiovisual entrainment device in a school to really just shift the moment. And we're not really thinking of that as neurotherapy. Right? That's not a treatment paradigm. It's a let's shift gears and get to the goal here, which is you back in class learning, us having a better experience and the teacher having a better experience and the parents who don't have to get a phone call having a better experience, right? Like that's kind of our goal. But if we think more about in-clinic and treatment, our course of neurotherapy is 40 sessions. And so part of that is what we're going for is permanence. So we like to think about something like 20 sessions is where we get the change that we want. Often by 20, many of the symptoms are starting to fall away, but we want to wire that in so it's permanent. And what we know from research is if we test somebody, so neurocognitive testing before they start, we test them at the end of their 40 sessions, we test them a year later, they're doing better than at the end of their 40 sessions. You test them another year later, they're doing even better. 3 years later, they're doing even better. So what we really do is we catalyze a process that continues. Research shows that at 7 years, if you test, they're still improving. So we catalyze a process, teach the brain how to optimize its own function, and it will continue to do that. The question I often ask people is, when is the last time you took a driving lesson? Probably at 15. Hopefully you're a better driver now than you were then. Not because you took classes, because you do it. And that's what happens. When we teach a brain a new trick, it will just use that over and over and over again. And then when it's learned that it can learn new tricks, it will start to develop its own tricks. And that's why we see, even after neurotherapy, they continue to improve. Your favorite question?
It's my favorite question. We do, in our clinic, we do out-of-network. And so that works for some. I would say maybe, 50% of our clients are utilizing out-of-network benefit to some level. Obviously, if somebody has MA, they can't use out-of-network benefit. So we've worked really hard. We have a packet that we provide as a resource for a particular waiver. If somebody is on county assistance, it's called a DD waiver. It's not the CADI waiver. It's a special kind of waiver. And we've had clients who, we had a mom who had 2 teenagers, really lots of dysregulation in both of them. She got the QEEG 40 sessions and an audiovisual entrainment device paid fully by that waiver for each one of her children. And then she was kind enough to provide us with some of the verbiage that she used on the goals that they used to write the waiver, because that's the real trick, is to make sure you write the goals well. And so we have those packets available as a resource that we hand out. I'm sure some of you have gotten that in your resource packet as you stop by, but that's kind of the deal with insurance.
And I'll just add to that. So relatively recently, maybe a year ago, one of the major insurance companies came out with a description of not covered services and explicitly wrote out the things that a clinic like ours does. So they're not moving towards covering it. They're going the other direction. They're moving away from covering it and putting in explicitly long descriptions of everything that anybody who does this, who tries to sneak it in, was using to describe it. They wrote out and said, not this. And that will move across all the insurers eventually. And so it is going to be a battle for this type of therapy to be covered under insurance. So I'll say, so there's what Fran said, kind of out of network. We have payment plans, there's the county waivers, and then there's an organization, Brain and Behavior Foundation, that does grants for neurotherapy. So that's an option. So it's not a an extensive program, but we do have people who come in through that, and they might have 25% grant or 100% grant. And so we have a wonderful collection of people who've been able to go through our program, having it paid for through Brain and Behavior. Yeah. So. Yeah, and that's great. That's another point is that IEPs can buy them the same way it would buy an iPad. It can buy an AVE. So that's another path for some funding. But I like that you kind of brought up kind of the co-regulation piece, right? That we all co-regulate. So regulated nervous systems help regulate nervous systems. So if the teacher is regulated or the classroom aide is regulated, they're better able to help the student regulate. So we love that idea, absolutely. So I saw a hand here, and then I saw a hand back there as well. Quick, go ahead. Oh, for sure. We have a great study that the organization that we belong to and kind of practice under, they did a large-scale study at an inpatient treatment facility. Outpatient? Outpatient.
They're outpatient.
Outpatient treatment facility, blew the standard of care out of the water. It was absolutely remarkable. And Blue Cross refused to pay, and they got the FDA involved. And the study, the data survived the FDA. They came out the other side and said, this was all positive, Blue Cross, pay it. Blue Cross did an audit, came out the other side and said, yeah, here you go, $2 million. And they expanded their coverage for that clinic. So again, we're gonna have to drag them kicking and screaming. And it's easier for them to cover the cost of a pill than to cover the cost of Fran or me. And they know that. An hour of my time is, worth, I don't know how much, but let's say, 500 pills. So they'd rather just do the pill and cut out everything else, right? I mean, so they're doing what they do, but you're 100% right.